Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is on neuromuscular problems, specifically multiple sclerosis, myasthenia gravis, and Parkinson's disease. The first disease process is going to be multiple sclerosis. This is a chronic, progressive, non-contagious disease. This usually will occur between the ages of 20 and 40 years old. From what I have read, this usually will affect more women than it does men. It's a demyelization of the neurons. And we'll go over the next couple slides as far as assessment-wise, but based on those demyelization of the neurons, your patient will experience a certain set of symptoms. They're going to have remission of those symptoms and exacerbation of those symptoms. The exacerbation could be due to fatigue or stress or infection or possibly even trauma. The remission, they're going to have good days and bad days. So the remission could be, oh, I feel really great, and they may feel great for a certain amount of time, but then they may have something happen, or they may overexert themselves, and then the symptoms will either get worse or they're going to start having bad days. This is thought to be a result of an autoimmune response or possibly a viral infection. So here is a picture of the multiple sclerosis concept. The fourth box is the picture of the damaged myelin. Myelin sheaths do not regenerate themselves or do not heal. So as that damage starts to happen more often, they start to have more symptoms, and the more symptoms they have or the more damage is done, the more progressive that disease process becomes. So as far as assessment-wise, your patient who has already been diagnosed with multiple sclerosis, if you do take care of somebody with multiple sclerosis in the hospital, usually they've come to you with either exacerbation of the symptoms or they've actually have some other disease process, and you just happen to be taking care of someone with multiple sclerosis. Again, they usually come to you with something else. The patient who has multiple sclerosis probably has some slight symptoms, went to the doctor, underwent some studies, determined that they actually had multiple sclerosis, and then they, started living their life from there. When they come to you, it's probably because of some sort of secondary issue or an exacerbation of this problem. So what we really need to realize is that, one, you're not going to cure them, but two, we need to actually try to teach them or try to give them the tools to take care of themselves as much as possible so they can actually stay out of the hospital. Assessment-wise, patients who have multiple sclerosis will have fatigue and weakness. They possibly may have ataxia or vertigo, may have tremors and spasticity of the lower extremities, which is usually later on in the disease process of multiple sclerosis. They may have some paresthesia, blurred vision, diplopia, and transient blindness. They may have some nystagmus, dysphagia, decreased perception of pain, touch, and temperature. And they're also going to have some bladder and bowel problems. Again, this is bowel and bladder problems are usually a spinal issue, and that's where your neurons and your nervous system is. So you may actually have some urgency, possibly some frequency, maybe even some retention and incontinence. Again, that damage to the myelin sheaths are causing the damage to the neurons, and again, that's really your urinary and bowel problems usually will come from there. So as far as assessment-wise, they are going to have normal reflexes. They possibly could have either some hyperreflexia or actually absent reflexes. Emotional changes, some of them actually have empathy, euphoria, irritability, and depression. And they may even have some memory changes or confusion. As far as diagnostics, if your patient comes to you and they have already been diagnosed with myasthenia gravis, they will actually have undergone an EEG, and this is to actually test those neurons and their function. They'll also possibly have done a lumbar puncture, and this will actually show an increased gamma globulin level in the serum. Intervention-wise, for you as a nurse, you're going to provide energy-saving measures during times of exacerbation. So again, if your patient comes to you, usually they come to you with either a secondary issue or an exacerbation of their symptoms. So basically what you want to do is try to save their energy as much as you possibly can. You also want to protect the patient from injury. These are patients who have lived the majority of their life independently as much as they possibly could, and once they get diagnosed, they try to be independent. They don't want people to try to help them, or they want them to believe that they need help. With that independence, that tends to cause some injuries. So we need to actually teach them how to be safe. Place an eye patch over the eye that's having the diplopia. That will definitely help be more of a safety issue, making sure that they can actually see well. Monitor for potential complications such as UTI, kidney stones, pressure ulcers, respiratory infections, or contractures. With the pressure ulcers, respiratory infections, and contractures, those are usually caused from the patient trying to reserve and save their energy as much as they possibly can. That's with them, I wouldn't necessarily say laying around the house, but that's them trying to, stay in bed and try to get their rest, and only having to do what they have to not deplete their energy resources. Because of that, they tend to break down a little bit more. If you're not getting up and walking around or doing a lot of things that will cause you to breathe deeper and better, you tend to get more respiratory infections. Patients who don't do exercises and try to stretch out what they do have, they tend to get some contractures. Again, I think those are probably more long-term effects, but again, as the disease progresses, they can do less. So the less they do, the more they have to, stay in bed or lay on the couch, and like I said, they're trying to reserve their energy as much as they possibly can, or may not have any energy. As far as the UTI, go back to the UTI lecture, in the sense that when we mentioned the multiple sclerosis symptoms, if they are having bowel and bladder problems, whether it's incontinence or it's retention, these will cause UTI problems. And again, your patient may come to you and be admitted for UTI symptoms and not necessarily a muscular sclerosis problem. So again, it's going back to the teaching of, do you know how you got this, and what can you do to prevent it, and try to keep them out of the hospital as much as you possibly can. Promote regular elimination of bladder and bowel training. Again, this is going to keep them, regular and things moving and moving consistently, and also allowing them to keep them from getting either small bowel obstructions, or by getting UTIs. So again, we can actually train them, and this goes back to basic, block one stuff. If you, train your patient to, get up in the morning and go to the bathroom, making sure that they're going to the bathroom at certain times of the day, and making sure that they actually keep things moving, especially with bowel training. Again, use lots of fiber and drink lots of water, making sure that things are moving the way they're supposed to. Encourage independence. It's interesting. I've had patients that have multiple sclerosis, and either they're too independent for their own good, and they end up getting injuries because they don't want the help, or they tend to lay in bed and not want to get out of bed because of the fact that they don't want to exacerbate their symptoms, or they can rely on other people to actually do stuff. So it's kind of that balance of getting them to be independent but not too independent. Establish regular exercise and rest programs. Again, if you don't use it, you lose it. So you want them to, do what they can, but try to exercise and use what you can as much as as often as you can, just so that way they don't get the atrophy and they don't lose the ability to walk, or to be able to do things on their own. Provide assisted devices. Again, we want them to exercise and to keep what they have as strong as they possibly can. But in the same sense too, as the disease progresses, they are going to get weaker. So it is okay for them to use a walker, or for them to use a cane, and to rely on them to be safe. But in the same sense too, it's better than them not actually walking or doing things on their own. Intervention-wise, you're going to initiate speech and physical therapy. Again, you want them to be able to be as independent and as strong as they possibly can for as long as they possibly can. You're going to avoid fatigue, stress, infection. The infection thing is probably more of, staying away from people who have colds, and making sure that they're up on their inoculations, making sure that they're washing their hands, making sure that they're, taking their flu shot every year. They want make sure that they don't have a reason to get sick. As far as the stress, it's hard to keep people from actually stressing out, or try to keep stress away from them. But in the same sense too, I think that the family can learn that the less you stress the patient, the more strength they're actually going to have, or the less exacerbation of the symptoms they'll have, and avoid fatigue. So, it's okay to sleep throughout the night and to get up and stay up for a little while and then actually take frequent naps, so that way you can actually get as much strength as you possibly can and to be less fatigued. As far as overheating and chilling, because of the myelin damage and because of the neurons having the problems, they don't have the ability to actually, or they lose the ability to actually determine what is either too hot or too cold. So regulate their bath water and making sure that they're not actually scalding themselves and getting some sort of burn. Avoiding heating pads, again, they don't have the ability to actually say, ow, that is too hot, so turn that down type thing. They also don't have the ability to go outside in the winter in the snow and realize that they're getting too cold and that they're actually causing some frostbite. So making sure that they can determine, or at least have somebody or have the ability to determine if something is too hot or too cold. Definitely increase fluid intake. The more they drink, the more they keep their system flush. The more they drink as far as fluids and keeping themselves hydrated, the more their bowels will actually move. So this goes back to the idea of keeping themselves, allows their bowel and bladder training. Make sure the meals are balanced with high fiber, low fat, high potassium diet. Provide information and support groups. It's okay for them to go and be with other people who have the same disease process. One will keep them from feeling like they're the only person that has it or feeling alone. It also allow them to be with other people and bond over a disease that people will be able to share ideas and things that they've actually been able to do to be independent and to keep themselves from not being in the hospital or keep them from getting sick. So the support groups are actually great. All right, so the next disease process is myasthenia gravis. This is also another neuromuscular disease. It's characterized by considerable weakness, abnormal fatigue of the voluntary muscles, a defect in the transmission of nerve impulses at the myoneural junction, and that's where it actually occurs. It is a decrease in acetylcholine and an increase in cholinesterase. It's unresponsive of muscle fibers to acetylcholine. So basically, it makes the muscles in the patient's body so weak that they can't actually, or don't have the energy to actually do anything or want to move. And this isn't just, oh, my arms are tired or my legs are tired and I can't walk. This is every muscle in their entire body. So this could actually affect their intercostal muscles in their chest. And this, that's what you actually need to actually breathe. And it allows you to inhale and exhale and have the strength to do that. So keep in mind that this is not just, big muscles. It's really everything from even blinking or breathing that actually affects it. Assessment-wise, again, your patients have weakness and fatigue. They're going to have difficulty chewing. They're going to have dysphagia, ptosis, diplopia, weak or hoarse voice, difficulty breathing, diminished breath sounds, and respiratory failure or paralysis. So again, this isn't just, oh, I can't walk and I can't move my arms. It's every muscle in their entire body. And I'll play a video in class where I'll actually show you this on a girl who has this, and it's actually very interesting. But again, it affects everything from the ability to swallow. I mean, again, you're using muscles to actually push food and peristalsis. They're going to have some ptosis and diplopia because of the muscles in the eyes. Difficulty breathing, and again, if you can't take those big deep breaths and inhale and exhale, you're going to start being diminished, and because of that you might start having some respiratory issues or possibly some disease processes like pneumonia. Intervention-wise, you're going to monitor respiratory status and the ability to cough and deep breathe, monitor for respiratory failure. You're going to maintain suctioning and emergency equipment at the bedside. Again, these patients don't have the ability to inhale and exhale. They also don't have the ability to actually cough. So if they're starting to get fluid buildup and they don't have the ability to actually cough that up and out, then things will start to settle. Definitely going to monitor vital signs, monitor speech and swallowing to prevent aspiration. You want to make sure that they're actually sitting up when they're eating. Assess muscle status. So, can they actually do the pushes and pulls and grips? Can they actually open their mouth and can they smile? Can they swallow? I wouldn't necessarily give them a hamburger to test their swallow ability, but giving them some ice cubes to suck on and swallow. And if they give that, clearing of the throat, maybe they really aren't swallowing as well, and they may need to get speech therapy to come and do some sort of swallow study. Definitely conserve their strength. The more strength they have, more rest time and naps that they could possibly take, the stronger they get. But the more they do, the more strength they actually lose. Plan activities that coincide with times of maximal muscle strength. So again, if they've just got up from a nap, that might be the time for them to actually get up and walk to the bathroom. If they just take a nap, it might be the time for physical therapy to come or have the speech eval. Don't wait until they've been up for several hours and they're starting to lose their strength, then all of a sudden try to get them to do stuff. Administer anticholinergic medication, and we'll talk about that when we go over the meds. Myasthenia crisis. This is an acute exacerbation of the disease. Can be caused by progression of the disease, infection, fatigue, stress, or not enough medication. So again, your patient is not coming to you with, oh, I don't feel well, and now I've been diagnosed with myasthenia gravis. They're coming to you because they have the disease and there's something else going on, and because of that, whether it be infection or stress or fatigue, or like I said, another disease process, this will exacerbate their symptoms. You're going to assess for increased heart rate and respirations and blood pressure. You're looking for dyspnea, anoxia, and cyanosis. Again, they don't have the intercostal muscle strength to be able to rise and fall their chest to allow them to cough or take those big deep breaths. You might see a decrease in urinary output, absence of cough or swallow reflex, and as far as interventions, you're going to increase the anticholinergic medication. The cholinergic crisis, this means that they've actually received too much anticholinergic medication. Assessment-wise, you're going to see abdominal cramping. And that's because now the medication went from giving them the strength and the ability to actually use those muscles to now all of a sudden there's too much medication, so it's causing more spasticity. So the abdominal cramping comes from that. They're going to have nausea, vomiting, and diarrhea. They're going to have blurred vision, pallor, facial muscle twitching, hypotension, pupillary miosis. Interventions is basically hold the medication. You're going to prepare an antidote, which is atropine. So again, this is really more of they've taken too much medication. They're now going from I feel extremely tired to oh, I felt great to now, oh my gosh, everything is completely on hyperdrive. So again, the easiest way to do it is actually hold the medication, and if it is too much of a crisis, atropine is going to be your antidote. For a patient to actually be diagnosed with myasthenia gravis, they're going to do something called a Teslin test. This is basically they're going to inject or administer Teslin. A positive Teslin test, their muscles have improved and they've actually gotten strength because of it. And that's what tells them that they actually have myasthenia gravis. If they provide the Teslin and there's no improvement in muscle strength, then that's not the problem. They have to figure out what else is. All right, so this next disease process is Parkinson's disease. This is a degenerative disease caused by depletion of dopamine, which interferes with the inhibition of excitatory impulses, resulting in a dysfunction of the extrapyramidal system. So basically, your patient has Parkinson's disease. It's because of a depletion in dopamine, which allows them, or doesn't allow them to actually control their muscle movements. So Parkinson's disease, this is a disease that is slow, progressive, and eventually crippling. Again, your patient is going to have some slight symptoms. They're going to go to a doctor. The doctor is actually going to diagnose them with Parkinson's, start them on a medication, and then they'll go from there. This patient will probably come to you with other factors or other disease processes, and that's where we'll go from there. Because of the slow progressive crippling disease, it results in falls, self-care, failure of body systems, and depression. So this is a perfect example of a disease process where somebody who has actually lived most of their adult life or most of their life being very independent and doing everything on their own. Because this disease is so slow to progress, the patient will do what they can as long as they possibly can, and even beyond their abilities will try to be as independent as they possibly can. And because of that, this definitely will cause more falls based on the fact that they're trying to be independent. This actually usually affects more men than it does women, and men tend to try to be as independent as they possibly can and don't ask for help, and that's what causes the injuries. Because of the symptoms of Parkinson's disease, it doesn't allow them to be independent when it comes to self-care, and also because of the disease progress and progression, its failure of the body systems and depression. I mean, who wouldn't be depressed after being diagnosed with Parkinson's disease and being able to be as normal, as independent as possible, and then start to go through these symptoms and to become less independent and have to rely on other people. It also will cause mental deterioration, but this occurs late in the disease process. As far as assessment-wise, this disease process will have bradykinesia, akinesia, the monotonous speech. Their handwriting will become a problem because of the tremors, which is usually in their hands and their fingers. As the patient becomes more fatigued, these symptoms become worse. So rigidity and jerky movement, restlessness and pacing, drooling, difficulty swallowing, speaking, loss of coordination and balance, and shuffling steps, stooped position, and a propulsive gait. So your patient is has a lot of stuff going on, and again, they try to be as independent as possible, but they lose a lot of this independence because of all these symptoms. Intervention-wise, you're going to assess neurological status and the ability to swallow and chew. High calorie, high protein, high fiber, soft diet with small frequent feedings. This is because the medication that's given, which is levodopa carbidopa or Sinemet, usually causes the slowing of all those symptoms, and with that causes slowing of the actual bowels. Because of that, they tend to get more constipated, and usually that's why we usually get them in the hospital. Again, you're not getting a patient that has these symptoms and they're going to be diagnosed in the hospital. Usually they have Parkinson's. They're coming to you because there's other factors, whether it be that they fell and broke something, whether it's not they're eating well, or maybe they're not able to actually swallow well and they're causing aspiration pneumonia. Those symptoms cause a lot of different problems, which then causes them to come to the hospital. Again, we're going back to small bowel obstructions, making sure that they eat well and making sure that they eat lots of fiber to keep things moving, drinking a lot of fluids, have them increase their fluid intake to 2,000 milliliters a day. Again, they're going to be monitored for constipation. Promote independence along with safety measures. So while they're in the hospital, get PT and OT to come and see them to see if they really are able to go home and live independently, or maybe there was an issue and that's what brought them there. Like I said, being independent, falling down and breaking something. Avoid rushing the patient with activities. Again, you do want to try to preserve their strength and give them lots of rest. Assist with ambulation and provide assistive devices like a walker or a cane. Again, get PT and OT involved to determine what they can and can't do. Encourage to lift feet when walking, because again, remember one of the symptoms is the shuffling gait. So you really want them to start to be able to lift their feet and actually be purposeful when they're walking. Promote proper posture, administer Parkinsonian medication to increase the level of dopamine. So again, we're going to go over levodopa carbidopa. Avoid foods high in B6 because they block the effects of the medication. So here's the medication, levodopa carbidopa, also known as Sinemet. So this is a combination of medication that is used to treat symptoms of Parkinson's or Parkinson-like symptoms such as shakiness, stiffness, difficulty moving. Parkinson's disease is thought to be caused by too little of natural occurring substance known as dopamine in the brain. So levodopa changes into dopamine in the brain, helping to control the movement. Carbidopa prevents the breakdown of levodopa in the bloodstream, so more levodopa can enter the blood through the blood-brain barrier. So again, you're giving two different medications into one pill, and one is to actually stop the symptoms or at least slow them down, and the other one's to actually help that medication stay in their system longer without being broken down in the system. And that's it. So bring any questions you have to class. Again, for these three disease processes, when you're actually studying and learning and reading about them, keep all this in mind that these are disease processes that cannot be cured. They're going to be coming to you as a nurse to the hospital for other problems, usually related to their disease. So it's really up to us to actually fix that problem first and then try to figure out how that actually happened and try to figure out how we can get them to either better understand or do preventative measures to keep them out of the hospital. And that's pretty much it. So let me know if you have any questions.